Hi everyone, I'm Anna Gutturi from the Cancer Center, and I have the pleasure of introducing today's Grand Round speaker, Dr. Dallas Reed. So Dr. Reed received her medical degree from Boston University School of Medicine and then went on to do an OBGYN internship and residency at Yale. She then pursued a fellowship in medical genetics at Mount Sinai in New York. And now, currently, Dr. Reed is an attending physician and assistant professor at Tufts University School of Medicine. She is also currently serving as the interim chief of genetics there. Over the years, she has received several prestigious honors and awards for her work. And most recently, in 2019, this is no surprise to me, she was recognized for her outstanding teaching efforts with a APGO Excellence in Teaching Award. She has also authored many publications, served on various committees, and has held various leadership positions. In addition to all these academic accolades, I know her through the collaborations that we've had about genetics. This is a field that's ever expanding and getting more and more complicated, and through our WellForce connection, she has been a great resource for a lot of us here in Lowell, and just want to thank her for being so welcoming and always so friendly and never makes you feel like you're bothering her or wasting her time, and look forward to a more formal collaboration in the months and years to come. So with that, I'll let Dr. Reed take over. Thank you.
Thank you. Sorry. Thank you, everyone, and everyone that's watching virtually. So just thank you for that introduction. Just to give you a little idea of what my world is like. So like Dr. Gutturi said, I did an OBGYN residency and then a medical genetics fellowship. So my job at Tufts is actually twofold. I am the interim division chief of genetics, and half of my clinical time is spent doing genetics. So it's all clinical. It's not research necessarily, but we see all of the pediatric and adult general genetics patients. We see all of the cancer genetics patients. And we do a little bit of prenatal genetics, although we have a separate group that does that, and I mostly do the more complicated prenatal sessions. And then the other 50% of my job is I'm still a general OBGYN, so deliveries and clinic and the OR. So it's very gracious that you say that Sue told me that I respond really quickly, and I appreciate that because I always feel like I'm taking too long since my sort of going in all different directions. But today I thought we would talk about cancer genetics for primary care, and it's really not just for primary care, it's for anybody that sees a patient who has a personal or family history of cancer. And, you know, with my OBGYN hat on, I know what it's like to have a very short amount of time with a patient and try to elicit some of this information. I have the luxury in genetics of having a whole hour with these patients to go over their family histories and talk to them and counsel them about the testing. But I'm hopeful that I'm going to give you some strategies or some things to think about as you're seeing your patients, and maybe a shorter than an hour type session to take with you. And at the end, I have a lot of sort of references. I'm not going to go through all those, but things that you may want to use or save somewhere so that you can quickly look up if a patient seems appropriate for genetic counseling. I don't think I have a slide about disclosures, but unfortunately I have no disclosures. So we're going to talk a little bit about sporadic versus hereditary cancer, some risk assessment, a little bit about what's happening right now with genetic testing, and then a little bit of when to refer, although I'm not going to go into a lot of detail. Those are some of the slides I was talking about that you can kind of look at later. And then management and post-test risk assessment. So I kind of want you to understand what happens when the patient comes to see us or see someone like us in genetics. Patients often show up and say, oh, I thought this was just a blood test. And it's an hour-long appointment, so we're doing much more than just a blood test, and I think it's important that there's a lot of good conversation before and after the results come back about why we do this and what it will tell us and what it won't tell us. So a little bit about the basics, just a little bit about how we talk to patients about cancer and some of the features and things you should be thinking about when you see a patient. So most cancers are sporadic, so we tell patients most cancers are sporadic, they just happen by chance, about 75% or maybe a little bit more. And these are due to acquired DNA damage. So as we are alive, living our lives, things happen that affect how our DNA looks, and mutations can pop up. So this can be, radiation, chemotherapy, UV, ionizing, or pollutants, various things in the environment. And then there can be other things that happen. We know that the DNA is always replicating and mistakes happen just normally. There's machinery in the body to correct those, but if one kind of slips through and doesn't get corrected, then that can lead to a mutation. So over time, as someone gets older, you have more and more of these insults, and these mutations can cause changes in the cancer genes and can increase someone's risk for cancer. So you'll hear we talk a lot about somatic versus germline when we're speaking about mutations in cancer. And it's becoming even more important as we're doing more and more testing related to tumors as well as blood testing. So somatic testing means a change that's just in the tumor or just in some of the cells. It's not a change that the person was born with. It's not hereditary. So most cancers, if you actually biopsy a tumor, you will see genetic mutations. That is how the cancer occurred. But in genetics, what we're trying to figure out is if someone is born with a mutation in all of the cells of their body. So that happens about 10% of the time that someone has a mutation that increases their risk of cancer. And it's usually in these genes called driver genes. I usually just tell my patients they're the cancer genes, so they're the ones that if they're working properly, they protect your cells from becoming cancer. But if there's a mistake or a mutation, it may increase your risk. So these mutations in hereditary cancer are germline. So that means I do a blood test, I biopsy the skin, I biopsy the eyeball, I'm going to see the same mutation in every part of the body, not just confined to the tumor. And so when we think of hereditary cancers, and one of the reasons why we're getting a family history and gathering personal history is because we see that these tumors oftentimes develop in younger people. They may develop more frequently, so someone may have multiple cancers or multiple cancers in the family. And we'll go into a little bit more about the different things to think about when you're seeing a patient with a personal or family history of cancer. So germline again, germline means transmitted through the gametes, so the sperm and the egg carry this mutation, and then therefore it is carried on into the embryo and then that developing person. Most cancer mutations are autosomal dominant, so what that means is if somebody has the mutation, there's a 50% chance they can pass that on to their children, and a 50% chance that their siblings also have the mutation. Most cancer genes mutations cause adult onset conditions, and this is why we don't typically do genetic testing for cancer syndromes in children. But there are some recessive or X-linked inherited cancer syndromes, and those usually present with a childhood onset of cancer. So a good example is Fanconi anemia. Fanconi anemia is caused by multiple genes in the body. It's a condition that causes short stature, cardiac issues, hand abnormalities, and anemia, and also learning issues, sometimes dysmorphic features. Many of the Fanconi anemia genes are actually cancer genes. So, for example, BRCA2 is a Fanconi anemia gene. So if somebody has one BRCA2 mutation, then they are at risk of breast and ovarian cancer, and we'll talk about that later. But if somebody inherits two BRCA2 genes, they have Fanconi anemia. So they present as children with that. So these are important things to think about when we're counseling patients about results, that even though, we may not just be talking about that 50-50 chance that their child has a cancer condition in adulthood, we may need to talk about their partner and what screening needs to happen for their partner to know if there's a risk of Fanconi anemia, for example, happening in their children. Those who don't inherit the mutation typically don't have an increased risk for cancer. A caveat to that is there's a gene called MUT-YH. It's a colon cancer polyp gene, and in those patients, it's actually a recessive disorder, but in patients who just carry one mutation, they do have an increased risk of colon cancer. Not as high as if they had two, but there is probably an increased risk. And then family history is a good predictor, but not definitive for knowing if somebody's at an increased risk. So more and more papers are coming out now that we're doing expanded and these bigger genetic testing panels, which we'll talk about later as well, but more and more papers are coming out showing that there are patients who seem to have not a concerning family history, where when you actually do the genetic testing, they do have a pathogenic mutation. And so, that's one reason why some of these other testing methods have taken hold, but maybe family history isn't the only thing. And as we know with Ancestry and 23andMe, people don't always know actually what their family history is. Sometimes they aren't even related to their family members like they thought they were. So there's always secrets in families. I learn about all the time when we take a family history. So what are the things, when you're seeing your patient and you're getting a history, what are the things that should make you think there might be a hereditary cancer syndrome in the family? These are the things we think about and look at. So if you see cancer in successive generations, so grandmother, mother, and that patient or that patient's generation has cancers, particularly if it's the same type of cancer. Age is a really important piece. So we know that breast, colon, those are very common cancers. So if there's 3 generations of people with breast cancer at 90, I'm a little less worried. But if they present all in their 40s with breast cancer, then I am more concerned. So age is really important, and you kind of have to think about what is the common age of cancer diagnosis for this type of cancer. Ages younger than that might increase your concern. Cancers or histology associated with a particular hereditary syndrome. So triple negative breast cancer is a very aggressive breast cancer. It's associated with BRCA mutations. Male breast cancer also associated with BRCA mutations. Very rare cancers or multiple primaries or bilateral disease. So if we have somebody that presents with breast cancer in one breast and then a couple years later a breast cancer in the other breast, that's concerning. Or someone who has an ovarian and a colon cancer diagnosed at the same time, or a uterine and a colon cancer diagnosed at the same time. Multiple benign lesions, so these can be a little bit trickier because things like fibroids, which are super common, if you see that in a family history with other, I like to think of growths, so polyps, colon polyps, maybe even breast fibroadenomas, that could be part of a cancer syndrome and might be something to think about. Don't send us every patient that has fibroids, but if you have a question, we're happy to answer that question. And then we know that in genetics, ethnic background can be important because of this phenomenon of founder mutations. So what those are mutations that are in a particular gene that are seen almost exclusively in a particular ethnic background. So we know that this is true for Ashkenazi Jewish mutations, especially in the BRCA1 and 2 genes. We know about this in other things like Tay-Sachs and cystic fibrosis, right? Like there's common mutations that are seen in Ashkenazi Jewish individuals. We've just, more recently learned that there's actually a founder mutation in BRCA2 in people that are of Portuguese descent. And so, the previous kind of round of genetic testing that was happening about 10 years ago wasn't actually looking for this particular mutation. So it is something now that when we see somebody with that background, we, even if they've had the testing before, we have to talk to them about repeating it. If there's any questions along the way, please raise your hand. So assessing risk. So this is kind of what we do when the patient comes to see us, although the first part of the homework is for what you need to do in the office to help conceptualize if this patient needs to be seen by genetics. So obviously we get a good family history, and if the patient has a history of cancer, we want to know all of the details of that. What age were they diagnosed? What was it? Not just breast cancer, but is there more details to the type of cancer? What type of treatment did they have for that cancer? And then when we get into family history, I say consider making a pedigree, which makes people a little bit nervous. But I think it does help to kind of think about the patient and the family as a whole and understand how concerned you are or how concerned we should be. So when we get a pedigree, or get a family history, we ask about all first and second degree family members. So all of the siblings, your children, and your parents are first degree relatives. And then second degree would be your sort of aunts and uncles, grandparents. We like to know how old they are now if they're living, if they aren't living, what they died from and at what age, obviously what side of the family they're on, and then if there's any history of cancer. And I tell the medical students that rotate with me in OBGYN, they're just sort of doing their thing and trying to check all the boxes, and they'll say, oh yeah, my aunt had breast cancer. Great. And they move on to the next question. We need some more information. So, why are we asking that question is to know if this patient's at risk for genetic syndrome. So we need to know what kind of cancer, if we know, what age it started or about what age, and if there's any knowledge about treatment. And now, more and more, we're asking, do you know if they had genetic testing? Because a lot of times, especially if it's a young person, and it was, in the last 10 years or so, they may have had genetic testing. And then if a relative is affected, so let's say my grandmother had breast cancer, then I'd want to know a little bit more about the brothers and sisters of my grandmother and my grandmother's parents. If people know, that can give us some more information and help kind of paint a picture for us. And then obviously ethnic background, which we've talked about before. So this is what a pedigree looks like. This is from the NCCN guidelines, which I have a link to at the end. But this is just, I don't know if anybody's drawn a pedigree, but to refresh your memory about what the pieces are. So basically, women are circles, males are squares. The arrow here indicates that this is the proband, so this is the person that's in your office, or this is your patient. And then these would be sort of first degree relatives are children, siblings, parents. Second degree would be kind of a step removed from each of those areas. So oftentimes, sometimes we may send this picture, or that patient may come with this picture to see us, which is really helpful to know what's going on. So one of the reasons we get that is because a lot of times we get this uninformative family history. So what does that mean? Patient's adopted or has no family information about their biological family, so that's very common, or sometimes they know a lot about one side but nothing about the other side. So that's not super helpful. Patient has no information regarding family members or cancer history, so this is very common. They're like, oh yeah, they had like some kind of cancer, I think. And you're like, okay. If family members died young, so if you're thinking of breast cancer, for example, if a patient comes to me and their mom died at 35 from a car accident, that's very much influencing a potential cancer risk in the family, because that mom didn't really live long enough for us to know if there was a cancer risk for her or not. So that's something we need to think about. Or if family members have had surgery that obscure risk, so this comes into play when we're thinking of hysterectomies, oophorectomies in particular. If their ovaries were removed at 47 because they had a cyst, they don't have ovaries now to develop ovarian cancer, so I don't know if I need to be concerned about that individual or not. When you're thinking of breast, ovarian, uterine cancer, if there's very few female family members, then that can be confusing. Or what happens a lot in our office, or at least in my OBGYN office, is the patient's 24 and their mom is 45. So the parents are very young and may not be old enough yet to have developed a cancer risk, even if there is a genetic mutation in the family. And then this is the most common. There was a stomach cancer. So I'm like, the organ, the stomach, or the stomach? And it's usually this thing. So, or female cancer is my favorite. So, this is completely unhelpful because the cervix has a different cancer risk than the uterus, than the ovaries. So we just kind of take what we can get, and we really try hard not to make patients feel badly about not knowing this information and say, just give us what you got, that's the best you can do, and then we can help make the decision from there. So as part of what we do in the office, and part of why a lot of times we're asking for lots of records, is because we're trying to get a whole picture of the risk assessment for this patient. So the history that we just talked about, often if there was genetic testing done in that patient or in a family member, we want to see it. We don't trust what anybody says. I have to see it with my own eyeballs to know what was actually done. I've had patients in my own GYN clinic fool me and make me think they had a particular mutation, and then when I got the report, I was like, ugh, should have listened to my own advice. Any imaging studies, any pathology reports. This is particularly important if you're thinking of Lynch syndrome or paragangliomas and pheochromocytomas. They often have particular types of staining that are done that can tell us if we're concerned about a hereditary cancer syndrome or not. And then a physical exam, not always, but there are some genetic conditions. One of them is Cowden syndrome. It's a breast cancer or uterine cancer condition, and there can be these little like growths on the ears, on the face, on the inside of the mouth. So sometimes we do an exam if we're worried about those conditions. And then what actually happens in the genetic counseling appointment after getting all of that history is a discussion about a particular cancer syndrome. So if a patient's coming to us for breast cancer counseling, we typically go into a lot of detail about BRCA1 and 2. We talk about what that condition is, what the management would be if someone was positive, the type of inheritance, which is, like we said, almost always dominant. We talk about who else in the family would be at risk if you were positive. And we talk about the risks, benefits, limitations, and alternatives to genetic testing. So patients that come to see us do not have to walk out of the door with getting genetic testing. One of the things that we talk to them about, particularly a patient who comes in just from a family history of cancer, is about a law called GINA. So GINA stands for the Genetic Information Non-Discrimination Act. It's a law that was put in place in 2008. And what it does is protect individuals from discrimination from employment and medical insurers based on a genetic testing result. So they can't be fired from their job and they can't be denied medical insurance. It does not protect people from long-term care, disability, and life insurance policies. So if they go out on their own to get one of those policies, like an individual policy, it's possible that they may be asked questions about genetic testing, and it's kind of up to them how they answer them, but they may be denied because of that. Yeah.
Is that a state or a federal law?
It's a federal law. GINA does not apply to people that are in the military or that have military insurance, or people that work for very small companies. So I think it's like less than 15 employees. GINA does not apply there. But we talk to patients about this, and many times patients say, I didn't know that. Let me get my life insurance and then I'll come back and we can do genetic testing then, which is great because we wouldn't want them later to be denied because they had no idea. Okay, so what do we do when we see genetic testing, or when we have patients come, and what genetic testing are we offering? So there are clinical guidelines that are in place by many different organizations. Insurers mostly follow the NCCN criteria. So if you're going to look at any criteria, that's the one I would look at. Testing is variably covered by insurers, so Medicare and Medicaid sometimes cover depending on the situation. Private insurers are much better at coverage. We talk to patients about the test is voluntary. They do not have to do it. We can still take care of them. We can still give risk assessment to them, even if they decide not to do the testing. And we have to get informed consent. So there's usually a consent form that has to be signed. There's a lot of conversation that goes into this testing before they actually do it. I would say that for Medicare covers testing only if someone themselves has had cancer. So if they have like a known BRCA mutation in their sister, Medicare still will not cover that. It's quite ridiculous, but that's what they say. So what are some of the advantages? And this is what we talk to patients about in the office. What are some of the advantages? Why would someone want to do genetic testing? The biggest reason that people come to us is usually to identify who's at risk and what the spectrum of cancer risks are. So we emphasize to the patient that when we do the genetic testing, a mutation in a gene, they may be coming in because of their family history of breast cancer, but each of these genes causes more than one type of cancer. So we may be talking to them about screening for other types of cancer or surgeries in the example of ovarian cancer for other types of cancer. So it's important for them to know we can't just ignore the other cancer risks. Sometimes there's a lot of people that want to denial and ignore. We have to talk about all of them. Another motivation, particularly with older patients, is predictive testing for family members. So they say, I'm not here for me, I'm just here for my daughter. And we kind of have to sort of refocus them and say, that's great, and that's a motivation for a lot of patients, but there are implications for you as well if you come back positive, and so you need to think about that before you decide to go forward with the testing. Cancer risk reduction, so we often get patients who either have cancer or are pre-symptomatic, so prophylactic surgeries are often an option, or heightened surveillance over what they would normally have. Chemo prevention with things like tamoxifen, and then lifestyle changes that can decrease the risk of developing cancer. A lot of the urgent cancer referrals we get are for surgical and treatment decision making, so this is most often with breast cancer. So patients will get a diagnosis of breast cancer and basically see us within a week or so to get the genetic testing started. It takes some time for the results to come back, because many times if they have a BRCA1 or 2 mutation, there may be a recommendation from their surgeon to do a bilateral mastectomy. The reason for that is that we know there's an increased risk of a second primary breast cancer that can happen, and it's quite an elevated risk. So they may just decide to do one surgery instead of one now and then later get another cancer diagnosis and get a surgery then. Or if you're thinking of Lynch syndrome, for example, we know that causes uterine, ovarian, and colon cancer, so we may counsel patients about removing their uterus and ovaries if they're at a certain age. A bigger reason now is reproductive options, so pre-implantation genetic diagnosis via IVF. So we can do that now. If we know that a mutation is in a family and that patient doesn't want to pass that on to their children, they can do pre-implantation genetic diagnosis and pick embryos that do not have that mutation. Translational research is becoming, this kind of goes along with the personalized medicine, so there's more and more and more and more and more things out on the market that are chemotherapy agents or targeted agents towards particular gene mutations or particular, just if a mutation is in a particular gene. So PARP inhibitors are really the big one, where in the past they were just being used for BRCA associated ovarian cancers. Now it seems like they're being used for all ovarian cancers and also as maintenance therapy, but survival is better in patients who have a BRCA1 or 2 mutation. So there's a lot of things on the market now that are coming out, and even this is for germline testing. There's more and more tumor testing happening now with agents being targeted towards mutations just in the tumor. And so we're starting to kind of pair those things together in the office as well. So in the past, really prior to 2014, the only tests available were these single gene tests. So that's where a patient would have just BRCA1 and 2, or maybe they would then come back and get P10, which is another gene, or maybe TP53, which is another gene. Many times, at least when we're thinking of the founder mutations, this testing was just looking at like hot spots. So if this is the BRCA1 gene, there's kind of 2 places for Ashkenazi Jewish individuals that we know are hot spots for that ethnic group, and that may have been the only testing that they had. So we're not actually looking at all the other places in the gene for mutations. The benefit of doing this is that we know that the patient met clinical criteria for that cancer syndrome. So you went to NCCN, they checked all the boxes, and you could say, great, we can order the BRCA testing. The problem is that there are other places in the gene in which mutations can be, as well as there may be genes that look exactly like BRCA. So early onset breast cancer, BRCA1 and 2 is not the only gene in which that occurs. There's many, many others. And so we're kind of missing that group of people if we only focus on one gene. So this is how genetic testing is done now. These are called gene panels via next generation sequencing. So all that is that we're looking at, we say all of the nucleotides, but it's really not. I mean, no genetic test, it has 100% coverage, but we're certainly looking at many more places in the gene than we were before. And also the panels will have more than one gene on them. Most of them have at least 9 or 10, and I'll show you some pictures of some of the offerings from some of the labs. We know that patients will meet criteria for at least one gene on the panel, but certainly don't meet criteria for every gene on the panel. And this becomes an issue with insurance coverage. So many times insurers will not cover the testing because of this. They'll say, well, they don't meet criteria for all 34 genes on that panel, so we're not going to cover it. So the labs have tried to get tricky and know which insurers will cover what, and essentially we order one thing and they on the back end sort of change the order so that it looks appealing to the insurance company. Because if not, then the patients wouldn't be able to get the testing done. And then there's a spectrum of possible results, which we'll talk about, and if you don't remember anything from my talk, this is the piece I want you to remember. So when we get any type of next generation sequencing test back, so this is not just cancer, when I see children with autism or seizures or hearing loss, it's the same thing. There's different types of results we can get back: negative, positive, or this uncertain finding. So typically negative or likely benign. Likely benign means we see a change, but we're 95% sure that that change means nothing, that that's kind of just a normal variation in the population. All of us in here have differences in our DNA. That doesn't mean they increase our risk for any problems. Positive means we found a mutation in a gene, we think it increases risk for cancer. We have to be very cautious when we talk to patients about this because we're doing these bigger panels, and it may be positive for a colon cancer gene, but they came to see us because of a breast cancer family history. So positive doesn't mean we've explained your history or your family history, but it does mean that there's something we need to do to screen you going forward, and there are increased risks for you or your family members. Likely pathogenic just means there's a 95% chance that we're 95% sure that it's a problem. And then this is the one that drives us all crazy. Variant of uncertain significance. So what that means is the lab sees a change in the sequence of the DNA. We're not unsure that the change is there. It is there. But the question is, what does the change mean? Since we all have changes that can mean nothing, and they may not have enough information to know if it actually breaks the function of the gene. So that's called a variant of uncertain significance. We talk to patients about this before we order the testing, because this makes them anxious sometimes and can drive them crazy. And so we need to kind of gauge their feeling about finding something like this. And I would say there's about a 30% chance we find one of these. So it's very common. We see them, and sometimes you see more than one on a test, depending on how big the test is. How these sort of interpretations get called is an interpretation made by the lab. There are some rules that all the labs follow, but then there's always internal databases and internal information that can skew it one way or another. So usually on the report, they have described what evidence they use to make the interpretation. And it uses things like available literature, what's happening with the family members. So do all the family members that have the cancer have the mutation, and all the people that don't not? There are some prediction models that are sort of computer models that say, if this mutation is there, how do we think it might affect the folding of the protein or something like that? And then in the lab's experience, so that's where they have internal databases where they have more information about particular changes just from other patients they've tested. So we talk to patients about this as well before we order the testing, which is what happens. Like, if it's positive, what happens? If it's negative, what happens? If it's uncertain, what happens? Positive usually makes sense to people. There's an increased risk of cancer. Oftentimes we can tell them how high. Most of the time we can give them recommendations about how to screen for cancer, or what prophylactic surgeries we would recommend, or what chemo prevention we would recommend, or who we would refer them to. There may be some genes on the panel where some of the cancer risks are unclear. For example, we can say there's an elevated risk of pancreatic cancer, but I can't tell you how high that risk is because we don't have that number. The negatives can be tricky. So negative would sound like it would be great. Although when I have a patient that comes to me with just a family history of cancer, no cancer themselves, and their family members have not been tested. So 25-year-old whose mother had breast cancer at 35, her mother is unavailable for testing, and she decides, yes, I still want to go through with the testing to see what my risk is. Comes back negative. Her risk is still not general population risk. So general population risk for breast cancer is about 12 to 13% in a lifetime. Her risk does not get to be that low because we don't know why her mother had breast cancer. Her mom could have had breast cancer from a genetic cause, maybe, or maybe not. And so what we tell people is that if you come back negative and you yourself have not had cancer, there's 3 reasons why. One is that there is a genetic cause for the cancer in your family, but since it's 50-50, you just didn't inherit that risk. The second is that there is a genetic reason, but we just didn't test the right gene because we don't know about the gene, or the test you had just was not full coverage. Or the other reason is that there isn't a genetic reason for cancer in the family, but there is something influencing cancer risk, and so that means your risk is a little bit higher. So this is where we go into sort of measuring their risk based on family history, and we'll talk about some of those models a little bit later. But patients need to know that if they haven't had cancer and they are negative and we don't know any genetic information about anyone else in the family, we're not sort of like, ooh, we're you're clear. This comes in a lot with ovarian cancer. So we get patients who come with a strong family history of ovarian cancer. And I'm like, if you're negative, I don't know what to tell you, because I can't really make your risk really low. It's still higher than it would be in the general population. So people should understand that before they think that this is going to answer all of those questions. And then VUS is not, like we said, not clearly pathogenic and not clearly benign, but because most of the time they end up getting reclassified to benign, we do not recommend that anybody make any type of medical decision based on an uncertain finding. There are lots of lawsuits of surgeons doing surgery on people with a VUS, double mastectomies, oophorectomies, and then patients having complications, and then subsequently finding out that that uncertain finding actually is benign. So if you don't remember anything, remember that VUSs are not a diagnosis, and you do not need to make any actions based on those. We often can talk to the lab and figure out if there's anything that we can do to clear it up. So if there are other family members we can test or other tests we can do, but it's not a diagnosis. So this is an example of one test that's out there. So over here are the genes. This is the name of the syndrome if there is one. And then up at the top are the types of cancer: breast, ovarian, colon, endometrial, melanoma, pancreatic, gastric, prostate, maybe other. So red means high risk, orange means elevated risk, so some type of middle risk. So that's one offering. This is another lab that this is a breast cancer panel, so it focuses on genes that are high or moderate risk for breast cancer, which means at least 2 times the general population risk for breast cancer. And here, this one at least lists, what are the percentage risk of developing cancer. So if somebody has a BRCA1 mutation, there's an up to 87% chance they'll develop a breast cancer, up to 54% chance they'll develop an ovarian cancer, etc. This is another test. So if a patient tells me that they or their family member has had genetic testing or BRCA testing, I have to see the test. I have no idea which of these 3 it was, or which of the 30 million that are out there it was. And especially if it was done years ago, it may have just been a very small test, and now we have some of these bigger tests, which, you can ask what's the utility of doing all of this, but, we're sort of fighting with insurance and trying to be the most cost effective all the time. So on these panels, things that we think about are that many of the genes are not well studied. That last one I showed you was 81 genes. You can wonder what is the clinical utility of looking at some of those mutations or some of those genes. A lot of this, and this is happening a lot in genetics, is that the testing is being pushed by the labs. So it's a commercial entity that's saying, oh, this is what you need to do, and this is what you need to offer, and this is what you need to give to your patient, and that's not always true. And so there's this battle between real-time understanding of what's going on, and that some of these are in some ways research, because we're later learning what are the actual risks, how common are mutations in these genes, etc. So we're a little bit learning as we go. We often, like I said, have patients that come to us for urgent appointments because they're going to be having a surgery for their breast cancer, so we need to time that in such a way that we can get the results back before surgery. It's at least 2-week wait to get results. Single gene testing is basically phased out at this point, although it depends on what the insurers are seeing with the billing piece. They may just be seeing that we're doing a couple genes, but usually that's not the case. Panels vary lab to lab, so I just showed you 3 different labs and what they offer. So we always need to see it in front of our face to know what was done. And really in our office, we don't just use one lab, we use several labs, and those decisions are made based on the patient's insurance. Really what we anticipate their out-of-pocket cost will be. So we try very hard to make sure there's no or minimal out-of-pocket cost, or if there is going to be an out-of-pocket cost, that they know what that is before the test gets started. Because no one wants a $2,500 bill coming. So I'm not going to get into this too much, but I thought that these would be some nice references that you could have somewhere later. But basically, these are sort of the things that we're thinking about in the personal and family history, and the types of conditions that we may consider based on that history. So I won't go through this because it's going through basically every cancer type: breast cancer, prostate cancer. I'll say now for prostate cancer, any aggressive prostate cancer, so Gleason score greater than 7, or any metastatic prostate cancer, the recommendations are now that those patients should be getting genetic counseling and offered genetic testing. So if you see that, that's kind of a change over previously. Colon cancer, it's usually early onset colon cancers with staining in the tumor that may show mismatch repair genes. That's more concerning for Lynch. Or if you see patients with many polyps, that's concerning for the polyposis syndromes, of which there are a couple. And then endometrial cancer is usually just Lynch syndrome and uterine cancer. Again, this is usually related to the staining with Lynch syndrome or age. Ovarian cancer, really any ovarian cancer should be getting genetic testing because those are considered rare enough. So any patient with a first-degree relative should be offered that. Cervical usually is not genetic unless they have this particular type, adenoma malignum, which is really, really rare. So this reference, nccn.org, if you don't know about it, I would recommend bookmarking this. There's kind of two references that they have. The genetic, this is the breast and ovarian cancer one, and then there's a colon cancer one. So some of these slides were taken from those. And then this I thought was a good reference as well. It's from the American College of Medical Genetics, which kind of, oversees genetics and genetic counseling to some extent. And a lot of those recommendations in the previous table came from this paper. So I would, if you want to have that one handy, I think it's helpful. So after we see a patient and they get a positive result, or they get a result, what are we talking to them about? I'm not going to go into the details of this either because it's kind of just a list of recommendations, but when they see us, we typically provide them with a letter that outlines all of this. We discuss it with them, and that letter goes to their referring provider and their primary care provider so they know what our recommendations are. But for BRCA1 and 2 mutations, we recommend basically breast exams by a physician starting at 25, annual MRIs starting at 25, and then annual mammograms and MRIs starting at age 30. Also having the option of a bilateral mastectomy for risk reduction if they so choose, and we tell them that both screening options are available and that this is a discussion for them to have with their oncology team. With ovarian cancer, there's always been a hope that there's been a screening test available for that, which there really isn't. CA-125 levels were previously thought to be a good test, but they haven't been proven to be that. We usually just use them to follow patients who've actually had ovarian cancer to look for recurrence. And so here it says consider doing transvaginal ultrasounds in CA-125. We really don't recommend that. The studies haven't shown that it decreases the risk of mortality from ovarian cancer. The other thing patients can do with ovarian cancer risk is birth control pills or some type of birth control. We know that suppressing ovulation likely decreases the risk of developing ovarian cancer. And we recommend strongly that the ovaries and tubes are removed at 35 to 40 or at the completion of childbearing, depending on what gene the mutation is in. Also, removing the ovaries can decrease the breast cancer risk, so sometimes patients want to do that instead. And still do the higher level of breast cancer screening. And then there are some recommendations or some thought about, who should be offered a risk-reducing mastectomy or risk-reducing bilateral salpingectomy and oophorectomy. So these lists I find helpful, but they're sort of changing over time as well, so it's good to get the most updated information. I'm not going to go through all of these because I think they're, again, just for reference. But like we talked about before, if a patient that's if they come back positive. If they come back negative, they're probably still at an increased risk of cancer based on their family history, and so we need to do some type of risk classification or stratification. So there's many models out there, in particular when you're thinking of breast cancer. There are some also for colon cancer. The one that I think is easiest to use is the Gale model. We typically use the Tyrer-Cuzick model because it takes into account family history a little bit more. But the Gale model is pretty easy. You can just Google it or go to this website. There's some pretty easy questions to answer. So in this example, this woman has not had her own history of cancer or DCIS or LCIS. She doesn't have a mutation. She's 38, had her period at age 12 to 13, her first child at age 20 to 24, and has at least one relative with breast cancer. No breast biopsies, and she's African American. So based on the Gale model, her 5-year risk of developing cancer is 1.2% compared to the general population risk of 0.5%, and her lifetime risk is 23% compared to the average woman of 10%. So the reason we need to kind of do this calculation is that the NCCN criteria say somebody's at an increased risk if their Gale model 5-year risk is greater than 1.7%, so this patient wouldn't have fit into that category, or if they have a lifetime risk of greater than 20% if you use models that depend on family history. So that's like the Tyrer-Cuzick, so that's why we use that particular model. The other thing is Gale model only works for patients over the age of 35, so you can't use it in younger patients. So if you have someone that's asymptomatic, and they come back negative, then we need to do this calculation to figure out exactly how high their risk actually is. And even if their testing is negative, but they screen above the 20% lifetime risk, then we would recommend that the extra screening with the MRIs and mammograms for them. Oh, I finished faster than I thought. Maybe there'll be lots of questions. So these are my take-home points. Get a thorough family history and try to update it frequently. If you're concerned about a hereditary cancer syndrome, have them come talk to us in genetic counseling. Even if they've had a family member who's been affected with the same cancer and had negative genetic testing, oftentimes that genetic testing is outdated or not as current, and we can provide some information for them. Sometimes your patient is not the most informative, so that 25-year-old patient I mentioned before with no breast cancer, her mom developed cancer at 35 and is still alive. I want to see her mom. I want to see the person who's actually had cancer, because that information is going to be more helpful than someone who's asymptomatic. And then definitive or surgical treatment is not recommended for a patient with a VUS, so do not do surgery on those patients if it's just an uncertain finding. Here's some good resources. These are a little bit OYN heavy, but also that American College of Medical Genetics guideline. NCCN and Gene Reviews is an awesome website if you don't know about that. Gene Reviews is like the up-to-date for genetic conditions. It's not just cancer, it's kind of any genetic condition. So let's say your patient comes to you with a particular diagnosis. This might be a good website to go to learn a little bit more about the condition, so that when you meet them you sound a little bit informed about what that rare condition is. And then this is how you can get a hold of me. I have cards too if anybody would like them. You can email me if you have a patient. The Cancer Center here does that frequently, emails me and just asks, this is the history, and sometimes there's questions that I return to get more info from them, but that way we can figure out if the patient does or doesn't meet criteria. And if you're interested in scheduling a patient, Tanya's our scheduler. You can call her, email her. You can always copy me on the email as well. Thank you.
Thank you so much.